Hello, my name is ZKJ, and my co-author is Gautam Pavar. This case is a case of avoiding penectomy in the setting of immunosuppression and an unexplained genital rash. A 33-year-old African-American gentleman presented to the ED for a 3x4 ulcerative lesion over the shaft and base of his penis. This lesion was initially non-painful, vesiculopustular, and umbilicated. These started on his face, then spread to his extremities, trunk, and back. He initially saw a local infectious disease doctor who instructed the patient to go to the hospital. This patient was later admitted to the DRH IM service for further workup. And the patient denied initially any sort of sexual activity. We consulted urology due to the size and location of the lesions, and they immediately put the patient on the board for debridement and excision and possible penectomy. The review of systems was completely benign, save for integumentary, which included a skin lesion. In terms of the skin lesion, there was a large ulceration on the penile shaft extending to the scrotum, but it was non-pruritic. In terms of the history and physical exam, on further interview, we found that this patient had HIV, which was diagnosed in 2016, but had not completely adhered towards proper follow-up with his infectious disease doctor, so he did not have a current CD4 count. He had newly established care in the local clinic, which prompted him to go to the hospital. In terms of family history and surgical history, there's no relevant data. In terms of medications, he was semi-adherent to Genvoya and was up to date on his immunizations. In terms of his sexual history, he later admitted to having sex with multiple male partners and was last active 1.5 months prior to his presentation. In terms of his vitals, he was normotensive, non-tachycardic, non-tachypnic, completely well and stable. And the only relevant physical exam finding was that there's this ulcerative lesion on his mid-penile shaft extending to the base of his penis and the scrotum, and distal penile swelling. There were other lesions on the trunk. However, those were in multiple stages of healing, most of them in healing. In terms of the patient's labs, there was no leukocytosis, surprisingly, and a slight microcytic anemia on his CBC. We were able to obtain a CD4 count, and unfortunately it was quite low, indicating this patient did have need of greater adherence to his Genvoya regimen for his HIV. And in the first couple of days, there was no growth to date after obtaining the initial wound cultures and swabs. We even obtained a COVID swab as well. After obtaining a CT abdomen and pelvis without contrast, which are depicted here, the radiologist informed us that there was an acute infectious process of the penile shaft, which we were able to correlate clinically, with extension into the inguinal lymph nodes bilaterally. There was a tiny 1.5 centimeter fluid collection at the penile base, and lymphadenopathy confirmed on CT, which was possibly an abscess with necrosis. In addition, there was a right-sided hydrocele. So at this point, our differential included a chancre due to a STD, such as Neisseria, syphilis, or HPV, genital herpes, monkeypox, and molluscum contagiosum, with our top differential actually being monkeypox. The final diagnosis for our patient was confirmed to be monkeypox with superimposed polymicrobial infection with 5 other microbes: Pseudomonas, Corynebacterium, Parabacteroides, Candida, and Trichosporin. How could this happen to this poor gentleman? Well, this gentleman had a low CD4 count, and destruction of CD4 positive T cells weakens the robustness of the immune response, which rendered him vulnerable to these opportunistic infections. There was a monkeypox outbreak documented as early as May 2022 in the United States. Previous outbreaks had been seen in the 1970s in other countries. And outbreaks have been documented to occur at gatherings for sexual intercourse throughout the U.S., which is a possible reason for how it got to this patient. This is a zoonotic organism within the genus Orthopoxvirus, which is related to molluscum. And it's important to realize that this is not documented as an STD by the CDC. This can be transmitted through human-to-human transmission, proximity with recently contaminated objects, skin lesions, or respiratory secretions. So this is a virus in which you would like to wear your N95 mask. In terms of symptoms, these are not necessarily all seen in the patient, but there are chills, exhaustion, fever, headaches, and muscle aches, in addition to the lymph nodes and rash being seen in our patient. In terms of the outcome for this patient, there were 2 excision and washouts and scrotoplasty, so no penectomy, thankfully, and wound vacuum placement with follow-up with urology outpatient in 3 weeks after the final washout. The patient eventually was discharged on a levofloxacin regimen and TPOXX, which is an antiviral, tecovirimat. And the patient was advised to continue their Genvoya usage to maintain higher CD4 count. These are our references.